Welcome to the show. I'm Dr. Ronald Yap, urologist and director of the Men's Urologic Health Program at Concord Hospital. Today, we will be talking about vasectomy with Dr. Scott Fabozzi. There are many ways for a person to achieve family planning. Vasectomy is a cost-effective, permanent way for a man to achieve elective sterilization and prevent an unintended pregnancy. Approximately 500,000 vasectomies are performed annually in America, with the vast majority being done by urologists. There are many opinions, myths, and facts surrounding the procedure, so I hope this episode will shed light on the topic and better educate the public on this very useful approach for male contraception. So here's a brief bio sketch for my guest today, Dr. Scott Fabozzi. He originally hails from Amsterdam, New York, and he completed his undergraduate degree from Cornell, then went to the University of Vermont for medical school. He completed postgraduate training in urology at Eastern Virginia Medical School. He's board certified in urology, and in addition to being a high-volume vasectomist like me at the hospital, he also is the director of the Kidney Stone Treatment and Prevention Program, and he's also the chief of our department. So welcome, Dr. Fabozzi. Good seeing you.
Thanks for having me, Ron.
Yeah, so first of all, I warm people up. So before we jump into the subject matter, I know you've been on staff for a long time at the hospital. Tell me about your journey. What brought you to Concord, and how's it been since you've been here,
Well, Ron, as you mentioned, I went to the University of Vermont in Burlington, did my residency in Norfolk, Virginia at the Eastern Virginia Medical School, and from there I had a service commitment to the state of New York and was in private practice for 3 years. But a job opportunity in Concord came up, and it seemed like the perfect place for me to set down roots, and moved here in the summer of 1998.
98, yeah. And you were urologist number 4 then?
So we were a group of 4 when I joined, but within a year of my arrival, one of our senior partners retired, so we were a group of 3 for a year.
Yeah, and now we just hired our 10th guy.
That's right.
So it's pretty amazing how things, just explode in the area. And also the practices have kind of evolved too, because, number 4, you're jack of all trades. And I think I came on, 06, jack of all trades, and now we've evolved to highly specialized practices. Can you tell the public just, we're talking about vasectomies here, but that's kind of in the realm of general urology. But as we've all evolved, just a few words just to plug what you're doing in the stone department before we jump in.
Sure. We're going to talk about vasectomy, but a big part of my practice is taking care of kidney stones, and along with the rest of the crew and with a very able advanced provider who works with me, her name's Cassie Delude. We run the stone treatment and prevention program, where we take care of both all of the surgical and the medical needs of all of our kidney stone patients.
Very unique, and shout out to Cassie, that was awesome in the program. But not many places where you have high quality stone care, not only the average Joe stuff that any urologist could do, but very complex stone work that Dr. Fabozzi specializes in, but also the metabolic stuff that was really started from the ground up. Now a lot of places do that here. So it's almost like a infomercial actually for your program. That's cool. So let's jump into the subject matter. So like I discussed, you and I do the majority, we actually essentially all of them now in our group, and we hired a new guy that's going to also pick up, the volume and do a lot, in the area. So you're definitely a natural for this. When we talk about the patient coming in, we spend a lot of time talking to them for that first visit. It's not just about doing the procedure and you're out of here. Can you give me a few words? What's the setup for the man that comes in who's interested in elective sterilization?
Sure. So we set up a specific time to sit down and consult about the procedure. Most of the young men who come in to talk about vasectomy have thought through their options, and they come in with a pretty set idea that this is what they want to do. But I like to talk with them about what their past reproductive history was, what their goals are going forward, finding out if they are aware of what other options for family planning and their reproductive health is, and make sure they understand where this fits in and make sure it's a good fit for them and their goals.
Yeah, sometimes I hear that they hear, oh, well, we'll do this, and I hear it can be reversed. And something that we like to tell patients about is that it's considered a permanent form. It could be reversed, but we would never do it with the intention that it be reversed. When you go through that general risk and benefit list, are there any like things that pop up for you when you go through the litany of things we're supposed to tell a patient?
Sure. So when I'm consulting with them first, if it seems like they have a good idea that and are very set on the fact that they understand this is a permanent sterilization procedure, then I run through with them the specifics of the procedure and then talk with them about what to expect during and after. And we, of course, talk about the risks. The procedure itself is in the realm of the type of surgeries that we do at the urology center would be considered on the low risk side of things, but it's not without any risk. I make sure they understand there is a very small, perhaps 1 or 2% risk of a complication. That can include things like bleeding complications, something called a hematoma. There is a very small risk of infection. Again, a 1 or 2% risk of pain, and some fellows will have chronic pain, generally a mild, controllable kind of thing, but I have to make sure they understand that that's a risk of the procedure as well. Mm-hmm. And then finally, the real important point is for them to understand there's actually a small risk, about a 1 in 1,000 chance that the procedure doesn't work and they are potentially fertile afterwards, and that pregnancy is possible after a successful vasectomy.
Mm-hmm. Yeah, well, nicely said. And that risk is about 1 in 1,000. And, I think that most things in medicine, I don't think there are many things out there that'll give you a 0.1% chance of failure, or just in life, actually. If someone told you there's a 1% this or a 0.1% chance of that, you're still talking pretty low. So I agree with you. It's important for a guy to know up front what they're getting themselves into. And this is very standard. I would say that for the public out there, my hope is that if you go see a urologist for this procedure, that you really do get sat down and you review those risks. And a lot of it could be like boilerplate. Our national organization does have a set of guidelines that we have a playbook on, but it's still important for a man to know those different risk factors. Now, so if you do any searching on Google about this stuff, you'll see kind of the AUA, which I mentioned, our national organization, and evidence-based type guidelines, but you also run into blog posts and perhaps some other, less informed people talking about that vasectomies can cause, my heart attack, vasectomies caused my erectile dysfunction, and, there's a question out there about prostate cancer, testicular cancer. Any thoughts, Dr. Fabozzi, on, whether we should talk about that with guys, or what's the deal with that?
Well, I think it's worth mentioning only in the spirit of trying to allay fears of any long-term risks of that nature. When I first started in training in the early 90s, there was a report in the Journal of the American Medical Association that suggested that there was an increased risk of prostate cancer associated with vasectomy, which has since been disproven. Along the way, there are periodic reports that come out from time to time suggesting long-term risks of things like heart attack or cardiovascular risks. And basically, there's no science that supports that. And we spend most of our time trying to allay those fears because there's really no long-term health risk association with this procedure.
And periodically you'll see something in the news, and you will see it pop up now and then. And you basically have a whole mound of studies over at least 40 years saying really not causing any of the things we had mentioned, prostate cancer, testicular cancer, erectile problems, heart disease. And then now and then something will kind of like pop up, well, maybe there is kind of sort of something. And these are all based on statistics, and a lot of times the threshold for there being a statistically significant thing would be 1 in 20. So if you study something enough, probably just on random chance alone, you may find a little bit of something. But even our national organization does actually tell us or admonishes us to please don't actually mention this very much, because it really just whips people up, and it's just really not proven in the medical literature. So let's get down to the procedure, because I got to say, you've been in practice, I think, 10 years longer than me. So you've got a couple thousand more under your belt. So you're like Vaz master. So talk me through how you do it, just for the public at hand.
Sure. So the procedure itself is one that's done, we do it right in the office. We do it with folks awake, no sedation, with a local anesthetic. Local anesthetic is where we inject a medication right into the site of surgery to numb up or anesthetize the area. General, it takes me from start to finish anywhere from 10 to 15 minutes. A lot of folks are surprised that it's not longer. Fella comes in, he's on an exam table. We clean off the scrotum with an antiseptic soap, and the vase, which is sort of a thin but muscular tube that you can feel with your fingers, is something that can be easily isolated underneath the skin, and a local anesthetic is administered. That's the part that patients really don't like the most, is the injection, but it's really nothing more than a pinch and a burn for a few seconds. And then really with just a small incision, there's a small break in the skin. The procedure is done by dividing each of the vas. There's one on each side. We use a cautery device to cauterize the ends. I like to use some small permanent clips as well on the vas to make sure it's completely occluded. And then with a single stitch, that's it.
And our techniques are very, very similar. And you'll see so many things out there on the internet about, do you use no scalpel, no needle, 1 cut, 2 cut, do you do this, do you do that? And I think, I kind of, like anything else, I mean, nothing's infallible, but just me doing it for 11 years, you now doing it, 20 years now, it's a very effective approach, and it's almost like the triple play. So when you take the tube and you excise a segment, there's physical separation, you cauterize the ends, they're charred up, and then you clip each end. There are a couple of layers of defense there to prevent reconnection or recanalization is what it's called, and very effective. And I think that nothing against the 2-cut people out there, but the modern technique is really to go, 1 incision, I think, nowadays.
Yeah, I think, Ron, we both use what is probably coined, the term that would be used is a minimally invasive approach. It's one where there's really minimal tissue injury or damage. It's a single small incision. And I think we feel very confident that that's an approach that's not only effective, but makes for a very quick recovery.
Sure.
Folks afterwards have a little bit of pain for 24 to 48 hours. Nothing more than a couple of extra strength Tylenol should manage it. And they're back to full activity in 72 hours.
Got it. And it sounds like that's the post-op pathway you tell those guys.
That's right.
The one thing, and I'd like to get your thoughts on it, the number one thing that I see in guys, it's not the procedure. There's a lot of anxiety about doing it, and a lot of it's just kind of getting in the right place, meeting the surgeon, feeling comfortable about that person you're having the procedure with. But it's also, in my experience afterwards, just like not being a guy, because the guys want to go home, and they want to, as soon as they get home from the vasectomy, they go, I'm all set, so I'm going to, rake the yard, I'm going to mulch, and I got a day off, so what I'm going to do is I'm going to chop a cord of wood, and then after that I'm going to, clean out the basement. And do you see something similar in your guys?
Yes. So one of the things I try to really coach them about is guys are surprised the day after the procedure how well they feel, and so they feel like they can go out and do just about anything, and they'll, just like you said, do yard work, or they'll get their usual run or their workout in. And I warn them that what they set themselves up for is the possibility of something called a hematoma. The way I describe it, so that they get it in their heads, is that if you bleed into the scrotum, it actually turns into this big purple eggplant, and it's really, really sad, and you don't want to be that guy.
You don't want to be that guy. Nobody wants to be that guy.
So don't be that guy.
Yeah, and it's a good image to have, just because we see that, and I think a guy experiences it hopefully one time in their life, but we've done thousands, and unfortunately that means, we see the 1% this or the, it's low numbers, and I guess not all of them are eggplants, but I'll tell you, even like a teaspoon of blood in your scrotum, it has nowhere to go. And you take a guy that maybe they pushed it, and maybe if they just took 48 hours and just chilled out and watched some TV and hung out, and then maybe take the first week and not go on that 100-mile bike ride or go take your motorcycle across the state, is that you're going to probably save that guy from maybe 2 months, because if you just have a little tablespoon of blood in there, you have the big eggplant, then, that guy's not out of commission for 2 days. He's out of commission for 2 months, or maybe he got another surgery, Right. Yeah. So, so now that it's done and they've recovered and everything's cool, back to usual work, what do you tell the guy about the checks afterwards? 'Cause that's another important part of the pathway.
Yeah, so we, of course, tell folks, and they really have to understand this, that immediately after a vasectomy, they're still fertile, and they need to use some type of birth control if they want to avoid an unwanted pregnancy. So whatever form of contraception they were using before the procedure, they need to continue afterwards because they still have viable sperm when they ejaculate. And the amount of time it takes for that for those live sperm to clear out is variable from guy to guy, but it's generally in the 2-month to 3-month range. All of the live sperm are out of the system, so to speak, and we have them come by the office and drop off a semen specimen at the 2-month mark. And if at the 3-month mark they have no viable sperm, then they can be assured that they have virtually no risk of fertility with those extremely rare cases of a procedure that either recanalizes or they have viable sperm after that point.
Sure, and I think that's like the most, I mean, aside from just taking it easy afterward, you got to come back, guys, for these checks, because if we don't know if it worked or not, it's like, you're kind of playing with fire. And we've seen some studies actually where the compliance rate is at times quite low for guys that come back. And every program's different. We like to use the 2-check method starting at month 2. And there's a lot of variability in the world wherever you're watching this. Don't take that to mean that the person that's doing it, if he does it in 8 weeks or 16 weeks or whatever, or does 1 check or 2 check, it varies. And there's a lot of, depends on the person. But the point is that you got to use backup birth control until the urologist tells you that it's okay, because there is a lot of residual. So if you visualize a testicle here and this tube that goes out and we interrupt it here, there's a lot of tube that goes into your body. And it's like turning off a garden hose. You don't just turn off the spigot and all of a sudden, there's a lot of, the water doesn't stop at the end of the hose. There's still a lot of water that comes out of the hose, and you gotta wait for it to all, evacuate. So, so we talked a bit about the technical stuff of it, 1 cut, 2 cut, no scalpel and all that stuff. And the aftercare and the semen analyses. I've seen some things where they really push, we use no needles and it's this and that and no scalpel. Do you have any thoughts about some of these marketing things that I've seen out there?
I'm not really familiar with anything other than a real standard vasectomy. Like I mentioned, we do use a minimally invasive technique. The technique of a no scalpel vasectomy is actually a viable one. It was one that was developed decades ago using some very specialized instruments. And I actually like using those instruments for the reasons we talked about earlier. It's sort of minimally traumatic. Mm-hmm. As far as alternative methods that actually don't involve any sort of break in the skin, I'm not familiar with them, and I can't really endorse that.
Yeah, no, I hear you too. And I only mention that because I did some background research, and patients actually ask. They come in and they go, "I've heard of a no needle, no scalpel, no nothing vasectomy," and some of it I think is just kind of, I don't want to mess with the people that are advertising these things, but I think there's, like you mentioned, Dr. Fabozzi, I mean, you got to do the procedure somehow, and if you don't use some way to get in the tissue, to get in there and numb things up and to, get rid of the, take care of business, it's just, like I said, be aware that you'll see a lot of things out there about different techniques, and I think in the end, you get along with the surgeon that's doing it, you feel comfortable with, the office and what they're doing for you, and a lot of the technical stuff will vary, but I would be a little hesitant to kind of, go for the guys that have billboards and claim that it's like, painless, no nothing, won't touch you at all type thing, because it has to happen somehow. Now, we mentioned very briefly the reversal part, and we really try to, if they really are thinking hard about doing it to be reversed, we really wouldn't want them, but any word about what that entails for the public out there?
Sure. So if after a vasectomy someone decides, either by a change in their life circumstance or just a change in their reproductive plans, that they want to have a biologic child after a vasectomy, there's a few ways that that could potentially be achieved. Vasectomy reversal is one of them. Basically, the concept of it is the 2 cut ends of the vas are sewn back together, and this is done as a much more involved, complex procedure than the office vasectomy that I described. This needs to be done in the hospital under an anesthetic with an operative microscope, and should be done only by someone highly skilled with a lot of experience in that procedure. Mm-hmm. The success rates vary depending on how long it's been since the vasectomy was done and the age of the partner. We quote a general sort of success rate, success meaning a successful pregnancy after a vasectomy reversal as about 50% likely. And now there's some newer options as well, including retrieving sperm from the testicle or the epididymis, which is right next to the testicle, and then using in vitro fertilization. So that's another alternative for someone who wants to have a biologic child after vasectomy.
Sure. And thanks for the overview. And I think it just depends on where you're at in the world. We live in Concord, New Hampshire, and we don't have a high demand for those types of services. However, we're about an hour away from Boston, and there's a lot of specially trained people. And it's not so much about the doctor end of it and the technical part of it as it is that you need that backup of a reproductive endocrinologist, an andrology lab, labs that look at semen quality to achieve a pregnancy. And the one thing too that's on the side is that depending on your insurance, the reversals typically aren't covered by insurance, and you're talking about a lot of out-of-pocket expense. So we only mentioned that whole pathway is that putting it back together is a lot different than doing the initial procedure. And you just need to make sure you think about it. And for most men, they're ready to as far as biological children, they're happy with their family and they're ready for that next step, and we're happy to provide that. And thank you for coming today, Dr. Fabozzi, and reviewing all this with us. And hopefully we'll see you next time. We'll bring you on for Stones again, man. And
looking forward to it, Ron.
Yeah, and we'll talk about that end of it. Okay. Thanks
Sure.
a lot.